Dr. Moughamian was paid for his time and participation.
Indication and important safety information including boxed warning. Indication. Kisunla is indicated for the treatment of Alzheimer's disease, AD. Treatment with Kisunla should be initiated in patients with mild cognitive impairment, MCI, or mild dementia stage of disease, the population in which treatment was initiated in the clinical trials. Important safety information for Kisunla, donanemab-azbt. Warning: amyloid-related imaging abnormalities. Monoclonal antibodies directed against aggregated forms of beta amyloid, including Kisunla, can cause amyloid-related imaging abnormalities, ARIA, characterized as ARIA with edema, ARIA-E, and ARIA with hemosiderin deposition, ARIA-H. ARIA usually occurs early in treatment and is usually asymptomatic, although serious and life-threatening events can occur. ARIA can be fatal. Serious intracerebral hemorrhages greater than 1 centimeter, some of which have been fatal, have been observed in patients treated with this class of medications. Because ARIA-E can cause focal neurologic deficits that can mimic an ischemic stroke, treating clinicians should consider whether such symptoms could be due to ARIA-E before giving thrombolytic therapy in a patient being treated with Kisunla. ApoE4 homozygotes, patients treated with this class of medications, including Kisunla, who are apolipoprotein EE4 ApoE4 homozygotes, approximately 15% of Alzheimer's disease patients, have a higher incidence of ARIA, including symptomatic, serious, and severe radiographic ARIA, compared to heterozygotes and non-carriers. Testing for ApoE4 status should be performed prior to initiation of treatment to inform the risk of developing ARIA. Prior to testing, the risk of ARIA across genotypes and the implications of genetic testing results should be discussed with patients. Consider the benefit for treating Alzheimer's disease and risk of ARIA when deciding to treat with Kisunla.
My name is Dr. Moughamian, and I'm the Medical Director of the Ray Dolby Brain Health Center and the Vice Chair of Neuroscience and Division Chief of Neurology at the California Pacific Medical Center. I'd like to share the experience of a patient who was treated with Kisunla, an amyloid-targeting therapy after diagnosis of mild cognitive impairment due to Alzheimer's disease. Linda is a 75-year-old Caucasian female who lives with her husband. She is retired from a career in healthcare. Her young grandchildren live nearby, so she is highly involved in their lives, has an active social life, and is motivated to maintain her independence longer. Linda's daughter brought her for an evaluation, thinking that something felt a little off, although neither was sure if there was anything to worry about. At the time, Linda reported that she was relying more on lists and reminders for everyday things. She also found herself misplacing things, and once or twice, she forgot she was supposed to pick up her grandchildren. However, she dismissed these occurrences as normal aging. Her daughter pointed out that Linda was repeating herself and had noticed a worsening of memory over the past year. Linda agreed to move forward with further evaluation. Linda has a history of hypothyroidism, hypertension, hyperlipidemia, and depression. I administered the MMSE and also the MoCA. Her MMSE score was 28 and her MoCA score was 25 out of 30, suggesting mild cognitive impairment. She is not a carrier of ApoE4. I referred her for a CSF test to evaluate for AD biomarkers. An elevated p-tau over A-beta ratio confirmed amyloid positivity. After testing and clinical evaluation, I diagnosed her with mild cognitive impairment due to Alzheimer's disease. Her baseline MRI showed no microhemorrhages or superficial siderosis. Given this, I felt she was an appropriate patient for an amyloid-targeting therapy such as Kisunla. Kisunla's safety and efficacy were evaluated in a randomized, placebo-controlled Phase 3 trial of patients with early symptomatic Alzheimer's disease. The study's primary outcome was the change in the iADRS score from baseline to 76 weeks, measuring cognitive and functional decline. This trial is unique in that once amyloid plaque were removed to minimal levels consistent with a visually negative amyloid PET scan, patients were able to stop and switch to placebo. Patients who took Kisunla showed a 22% slowing in cognitive and functional decline versus placebo at 18 months. Patients who were earlier in disease progression demonstrated a 35% slowing versus placebo. Linda and I discussed what more time in the early stages of AD could mean. I shared with Linda, her daughter, and her husband that patients who took Kisunla showed a 37% lower risk of progressing to the next stage of disease versus placebo throughout the course of the study. This is important because it helped keep patients in the earlier stages of disease longer. A post-hoc exploratory analysis showed 50% reduced risk of progressing to moderate or severe AD. We know that patients at these stages may experience a greater impact of the disease on their daily functioning. We not only discussed the potential to slow her cognitive and functional decline, but I also addressed treatment risks, including ARIA, which may be serious and life-threatening. As seen in the Phase 3 Trailblazer 2 trial, the common adverse events are ARIA, headache, and infusion-related reactions. ARIA-H microhemorrhage was observed in 25%, ARIA-E in 24%, and ARIA-H superficial siderosis in 15% of patients. The safety profile of Kisunla was updated in July 2025. See Kisunla's prescribing information and continue listening for important safety information for additional details. I shared that ARIA is usually asymptomatic. 6% of patients treated with Kisunla in Trailblazer 2 experienced symptomatic ARIA. It is important for patients undergoing treatment to be aware of this risk and carry a patient card in case of emergency, because symptoms may mimic an ischemic stroke. I put the risk in context, so Linda and her loved ones understood the possibility of ARIA. While symptomatic treatments can help address symptoms, amyloid-targeting therapies can help slow disease progression. Linda's goal is to maintain her independence and stay in the earlier stages of early symptomatic Alzheimer's disease as long as possible. Therefore, she chose to proceed with treatment. Linda started infusions of Kisunla every 4 weeks at a local infusion center in a hospital. She's had 7 treatments thus far and underwent an MRI prior to infusions number 2, 3, 4, and 7 to monitor for ARIA. Scans have been negative for ARIA, and she has not exhibited symptoms suggestive of ARIA. To date, she's tolerating the therapy well and reports no new memory complaints. For Linda, we plan to perform an amyloid PET scan after 18 infusions to provide direction on whether to consider stopping treatment. However, clinicians should use their own judgment when assessing to stop treatment. Linda and I are pleased with her current response. Results may vary, but Linda's clinical outcomes are consistent with those reported in the Phase 3 trial. I feel hopeful being able to offer patients a disease-modifying treatment. If we can slow the progression of the disease and keep patients in an early stage longer, I feel we're making a meaningful difference for patients. I recognize that getting patients the workup for amyloid-targeting therapy is complex, involving the patient and family, but do feel strongly that appropriate patients should be given the option of treatment. I just want the patient and family to make an informed decision.
Indication and important safety information including boxed warning. Indication. Kisunla is indicated for the treatment of Alzheimer's disease, AD. Treatment with Kisunla should be initiated in patients with mild cognitive impairment, MCI, or mild dementia stage of disease, the population in which treatment was initiated in the clinical trials. Important safety information for Kisunla, donanemab-azbt. Warning: amyloid-related imaging abnormalities. Monoclonal antibodies directed against aggregated forms of beta amyloid, including Kisunla, can cause amyloid-related imaging abnormalities, ARIA, characterized as ARIA with edema, ARIA-E, and ARIA with hemosiderin deposition, ARIA-H. ARIA usually occurs early in treatment and is usually asymptomatic, although serious and life-threatening events can occur. ARIA can be fatal. Serious intracerebral hemorrhages greater than 1 centimeter, some of which have been fatal, have been observed in patients treated with this class of medications. Because ARIA-E can cause focal neurologic deficits that can mimic an ischemic stroke, treating clinicians should consider whether such symptoms could be due to ARIA-E before giving thrombolytic therapy in a patient being treated with Kisunla. ApoE4 homozygotes, patients treated with this class of medications, including Kisunla, who are apolipoprotein EE4 ApoE4 homozygotes, approximately 15% of Alzheimer's disease patients, have a higher incidence of ARIA, including symptomatic, serious, and severe radiographic ARIA, compared to heterozygotes and non-carriers. Testing for ApoE4 status should be performed prior to initiation of treatment to inform the risk of developing ARIA. Prior to testing, the risk of ARIA across genotypes and the implications of genetic testing results should be discussed with patients. Consider the benefit for treating Alzheimer's disease and risk of ARIA when deciding to treat with Kisunla. Kisunla is contraindicated in patients with known serious hypersensitivity to donanemab-azbt or to any of the excipients. Reactions have included anaphylaxis. Amyloid-related imaging abnormalities, ARIA. ARIA usually occurs early in treatment and is usually asymptomatic, although serious and life-threatening events, including seizure and status epilepticus, can occur. ARIA can be fatal. When present, reported symptoms associated with ARIA may include, but are not limited to, headache, confusion, visual changes, dizziness, nausea, and gait difficulty. Focal neurologic deficits may also occur. Symptoms associated with ARIA usually resolve over time. In Study 1, safety was assessed in patients who received Kisunla dosing regimen 1, N equals 853, compared to those who received placebo, N equals 874. In Study 2, the effect of different dosing regimens of Kisunla on ARIA was assessed, including in patients who received Kisunla dosing regimen 2, N equals 212. Incidence of ARIA. A lower incidence of ARIA was observed with dosing regimen 2 as compared to dosing regimen 1. Therefore, dosing regimen 2 is the recommended dosage for Kisunla. In Study 1, symptomatic ARIA-E occurred in 6% of patients through 18 months of treatment with Kisunla. Clinical symptoms associated with ARIA resolved in approximately 85% of those patients. Including asymptomatic radiographic events, ARIA, ARIA-E, and ARIA-H were observed with Kisunla, 36%, 24%, and 31% of patients treated with Kisunla, respectively, compared to 14%, 2%, and 13% of patients on placebo. There was no increase in isolated ARIA-H for Kisunla versus placebo. In Study 2, symptomatic ARIA-E occurred in 3% of patients and symptomatic ARIA-H occurred in less than 1% of patients through 12 months of treatment with Kisunla. Clinical symptoms associated with ARIA-E resolved in approximately 67% of patients at 12 months. Including asymptomatic radiographic events, ARIA, ARIA-E, and ARIA-H were observed in 29%, 16%, and 25% of patients treated with Kisunla. Incidence of intracerebral hemorrhage, ICH. ICH greater than 1 cm in diameter was reported in 0.5% of patients treated with Kisunla versus 0.2% on placebo in Study 1 and in 1% of patients treated with Kisunla in Study 2. Fatal events of ICH have been observed in patients taking Kisunla. Risk factors for ARIA and ICH. ApoE4 carrier status. The risk of ARIA, including symptomatic and serious ARIA, is increased in ApoE4 homozygotes. Recommendations for management of ARIA do not differ based on ApoE4 carrier status. Testing for ApoE4 status should be performed prior to initiation of treatment to inform the risk of developing ARIA. An FDA-authorized test for detection of ApoE4 alleles is not currently available. Currently available tests may vary in accuracy and design. Radiographic findings of cerebral amyloid angiopathy, CAA. Neuroimaging findings that may indicate CAA include evidence of prior ICH, cerebral microhemorrhage, and cortical superficial siderosis. CAA has an increased risk for ICH. The presence of an ApoE4 allele is also associated with CAA. The baseline presence of at least 2 microhemorrhages or the presence of at least one area of superficial siderosis on magnetic resonance imaging, MRI, which may be suggestive of CAA, were identified as risk factors for ARIA. Patients were excluded from enrollment in Study 1 and Study 2 for findings on neuroimaging of prior ICH greater than 1 cm in diameter, greater than 4 microhemorrhages, greater than one area of superficial siderosis, severe white matter disease, and vasogenic edema. Concomitant antithrombotic or thrombolytic medication. In Study 1, baseline use of antithrombotic medication, aspirin, other antiplatelets, or anticoagulants, was allowed. The majority of exposures to antithrombotic medications were to aspirin. The number of events and the limited exposure to non-aspirin antithrombotic medications limit definitive conclusions about the risk of ARIA or ICH in patients taking antithrombotic medications. One fatal ICH occurred in a patient taking Kisunla in the setting of focal neurologic symptoms of ARIA and the use of a thrombolytic agent in Study 1, and one fatal intracerebral hemorrhage occurred in the setting of ARIA and the use of a thrombolytic agent in Study 2. Because ARIA-E can cause focal neurologic deficits that can mimic an ischemic stroke, treating clinicians should consider whether such symptoms could be due to ARIA-E, and additional caution should be exercised when considering the administration of antithrombotics or a thrombolytic agent, e.g., tissue plasminogen activator, to a patient being treated with Kisunla. Advise patients to carry information that they are being treated with Kisunla. Caution should be exercised when considering the use of Kisunla in patients with factors that indicate an increased risk for ICH and in particular for patients who need to be on anticoagulant therapy or patients with findings on MRI that are suggestive of CAA. Monitoring and dose management guidelines. Obtain a recent baseline brain MRI prior to initiating treatment and prior to the second, third, fourth, and seventh infusions. Enhanced clinical vigilance for ARIA is recommended during the first 24 weeks of treatment with Kisunla. If a patient experiences symptoms suggestive of ARIA, clinical evaluation should be performed, including MRI if indicated. If ARIA is observed on MRI, careful clinical evaluation should be performed prior to continuing treatment. Recommendations for dosing in patients with ARIA-E and ARIA-H depend on clinical symptoms and radiographic severity. Depending on ARIA severity, use clinical judgment in considering whether to continue dosing, interrupt treatment, or permanently discontinue Kisunla. See prescribing information for additional dosing considerations. Hypersensitivity reactions. Hypersensitivity reactions, including anaphylaxis and angioedema, have occurred in patients who were treated with Kisunla. Promptly discontinue the infusion upon the first observation of any signs or symptoms consistent with a hypersensitivity reaction and initiate appropriate therapy. Infusion-related reactions, IRR. IRRs were observed with Kisunla, with the majority occurring within the first 4 infusions. Most IRRs occurred during the infusion or within 30 minutes after completion of the infusion, however some have occurred hours after an infusion. Signs and symptoms of IRRs include chills, erythema, nausea/vomiting, flushing, difficulty breathing/dyspnea, sweating, elevated blood pressure, headache, chest pain, and low blood pressure. In the event of an IRR, the infusion rate may be reduced, or the infusion may be discontinued, and appropriate therapy initiated as clinically indicated. Consider pretreatment with antihistamines, acetaminophen, or corticosteroids prior to subsequent dosing. Adverse reactions. The most common adverse reactions reported in greater than or equal to 5% of patients treated with Kisunla and greater than or equal to 2% higher than placebo were ARIA-H microhemorrhage, ARIA-E, ARIA-H superficial siderosis, headache, and IRRs. Kisunla, donanemab-azbt injection for intravenous use is available as a 350 mg per 20 ml single-dose vial. Please see full prescribing information for Kisunla, including boxed warning regarding ARIA, and medication guide. Kisunla is a trademark owned or licensed by Eli Lilly and Company, its subsidiaries, or affiliates. Voice-over audio created using AI.